That one was very good. We got a lot of this is I'm looking more and more.
Hey everybody. So I know you're getting cookies, getting the blood sugar up, milling around a little bit. Just to try and keep us on schedule, I'm going to get started a tiny bit early. We actually, right before we have Gene Ransom come up as our keynote, We're lucky to have Dr. Jonathan Thierman here to say a few words. So, in general, I think hopefully you've all realized how much we value, especially clinical input into the services. One way we do that is through a number of committees and stakeholder groups. One of those is the clinical committee. This is a subcommittee to our board, and they meet at least quarterly, and they're the ones who work through use cases and data and what are the critical things that a provider, a physician would need from CRISP. For actually the entire 10-year history of CRISP, that's been led by Dr. Mark Kellerman, who still participates very frequently with us, and it's been one of the guiding clinical voices. It is now being taken over by Dr. Jonathan Thierman, who is the Chief Medical Informatics Officer at LifeBridge Health. He's an active ED physician, and just a really bright guy. And so I want to invite Dr. Thierman up to say a couple words, and then we'll go on to Gene.
Hello, good afternoon. Wow, there's volume there. Welcome back into the big room. I just wanted to say hello and introduce myself. Thank you, Craig. So Craig and David asked me to do a couple things in a few minutes, so I'll try and accomplish the goals in a short period of time, a couple minutes. I just wanted to tell you who I was, tell you a little bit about LifeBridge, and then even though I haven't yet chaired a clinical committee, talk a little bit about some ideas for vision and plans for the committee. And then I'll end with a funny story, because that's always a good way to end. So I'm an ED doc. I came to Maryland from Boston. I started out life as a nerd. I was a math major in college. I quickly realized I almost flunked out of freshman year advanced math and freshman year math, because they kept putting on the problem sets and the final exams prove an existence to the solution of a problem. And I kept solving the problem and saying, there's the solution, therefore it exists, 0 credit. So my math professor said, you're really more of an engineer, because engineers care about the answers. Math majors don't care about the answers, they care about knowing that one exists. I don't understand why. And so I switched quickly to engineering. So I started out very technical, doing engineering stuff, and I quickly found that I wanted to do something that mattered and made a difference. So I worked my way backwards into medical school in medicine, and eventually to the ER, where I came to Maryland to train at Hopkins. And that's how I found my way here, and I really like it here. I've been here 11 years now. So now I have worked my way back into the technical side after doing full-time ER for 5 or 6 years. I want to do more of what I loved, which is the engineering and systems things. So I kind of backtracked into that, and currently, for the last 2.5 years, I've been the Chief Medical Informatics Officer at LifeBridge Health. And recently, I'm the medical director of the virtual hospital, which we're building, which will do a lot of neat telemedicine and population health and other types of things like that for our communities. So I'm really, really excited to be here. I'm really excited to be part of CRISP. LifeBridge Health has been involved with CRISP since the very beginning. We've chaired through our 2 CIOs the IT committee for CRISP since it was its inception. And CRISP has been a big part of LifeBridge. We use CRISP in all the different features and manners. We use ENS, we use PDMP, we use in-context alerts. We're on a Cerner EMR for the most part. We have single sign-on through the EMR. And more recently, and very excitedly, we've been using a lot of the image exchange as we have acquired other hospitals, and we've centralized our neurology program. So especially for stroke transfers, we've been using the image exchanges to help with transfers and coordinating strokes from Carroll down to Sinai for the most part, and also Northwest. All right, I did that. So plans and visions. This was the hard one because I'm new and I haven't yet served on the committee. So I can tell you some ideas. My number one job, first of all, is just to listen and to learn, to try and understand what the initiatives are. One thing that I feel makes me well suited is I'm a user of CRISP as an ER physician. So I still practice every week, and I use CRISP all the time, and I've been there, over the years as CRISP has been enhanced and developed. So I find that I can bring a perspective of a user as a frontline user, not the same type of users. There's a million different types of users, and I'm one type, but at least someone who uses it and can feel the pain points and have suggestions and things like that for the clinical committee. The way I break down kind of the vision is twofold, a micro and a macro. So zooming in micro, I think that usability enhancements in terms of the user interface, making it just more accessible data is a goal of mine in general. And I think that just understanding some of the problems, I mean, I've been, officially the chair of the clinical committee for like a few weeks, and I've already had a dozen people from our system come up to me and ask me to make sure that on the agenda is this little thing or that little tweak or whatever. So I hope I can bring some good things that way to the committee. And then in terms of macro, I think that I'm excited to be part of helping shape the vision as medicine moves beyond the four walls, beyond the offices, really into the communities and even into the homes. The value of CRISP and thoughtfully expanding the access to CRISP to other types of providers and caregivers, I think is a macro vision that I have for CRISP. All right, so the story. So it's not super funny, but it's kind of ha-ha funny. Thank you. So if I kind of think about my life, funny things happen to me all the time, and so I was just lucky enough that something funny happened on the way here, so I can tell you about it. I was trying to get here from Sinai, and that's in northern Baltimore City, and I'm a big fan of Waze, so I'm kind of rushing through the 1,000 or 1,100 steps, but who's counting, from my office to the parking lot, and I'm putting in the address for here, hoping to get the estimate be on time to be here. And as I'm typing in the address, Waze has this pop-up, which we all know from the EMRs, the pop-ups, and it stops me and it says, oops, which I think is kind of cute. It says, oops, drivers are prohibited from putting in directions while driving. Are you a passenger? And I realized I was walking so quickly that Waze, I guess I had like 3 or 4 miles per hour under me, and Waze stopped me. And I didn't know how to respond, but I was like, you know what, I'll be a passenger. So I was I'm not going to slow down. I had to get to my car. So I was a passenger. And I've never done that as a driver, actually using Waze. But I'm a passenger, and then I got my destination, and it actually gave me turn by turn because I thought I was lost. I was still in the hospital trying to walk to the car, but it was like make a left, make a left, and I know how to get to my car. So that was the funny story. Thanks for laughing. I appreciate it. But the kernel of truth in this is just that it highlights the importance of usability of technology. So Waze has a lot of very important uses, and there's a lot of data that's useful, but it's not just the type of data that's important, but also the delivery of the data. So I want to think about that as it applies to CRISP, and I want to try and help both the types of and hear from people the types of data that are important to deliver, as well as maybe little things about CRISP that can help the delivery of the data make it more usable. So with that, I will end my 5 minutes of introduction. I'm very, very excited to be here. I think CRISP is a great organization that just continues to evolve, and I'm always amazed and impressed with the continual new projects. It's certainly not resting on any laurels, and it's moving forward quickly, so I'm just happy to be a part of that. Thank you very much.
All right. That was great. So we have like 1.5 keynote. This is perfect. So Gene Ransom is the CEO of MedChi. He's been a longtime advocate of physicians. He's been a longtime advocate of CRISP since the very beginning. He's been an advocate of health reform and all the great stuff that the state's doing. So we're really happy to have him share his thoughts.
So thank you so much for the opportunity to speak with you guys today. My plan today was to talk a little bit about where CRISP was and where it's going. But I think it's important for us to take a pause real quick and think about where we are right now, and that's always a good thing to do. So in my role as the CEO of the State Medical Society, which I've had for the last 10 years or so, I've gotten to do a lot in organized medicine. In fact, I've now worked for MedChi for 20 years, 22 years actually, last month, amazingly. I don't know how that happened. I guess I'm just not smart enough to get another job. But nonetheless, because of that, I get to be on all these national committees. I go to these big AMA meetings and meet other people. And one of the things I think it's really important to do, because we have a tendency to think about where we are, is to compare us to other places. When I talk to my colleagues in other states, they are envious of how wonderful the HIE here is. And they just think it's incredible what we have. And they ask questions like, how does that work, or how are you able to do that? And there are a lot of reasons why we're successful. Obviously, the partnership, and Chris is here from the HSCRC, the waiver helps us because it creates a funding source that helps us out. The fact that Maryland was smart enough to create one nonprofit entity and not have competing HIEs was terrific. The fact that you've got incredible staff at CRISP. I mean, David Horax, who's been here from the beginning, Brandon, Craig, who's doing a great job, all these folks who really care, and I'm not mentioning enough of them because there's so many there who work so hard, make it a great thing. But we are so lucky to have what we have. If you think about it compared to other states, we're running more information than other states. Every hospital is connected here in Maryland. So if you just take a second to think about what we've got, we're so lucky, and that's a good thing. So the next time you're frustrated because something isn't working or it's not right, you could be in a place where literally there's no data running at all, or they took all the money from the HITECH Act and wasted it and the place is defunct, or they have literally nothing, or they're depending on an insurance company or something like that. So like I said, I think it's always good to start with where we are, and we're in a really good place. So having said that, I guess I should probably tell you all who MedChi is. Now, a lot of you, and I see a few members in here. I saw Dr. Davis and a few other folks. There you are, Dr. Davis, and a few other members. But for those of you who don't know what MedChi is, it's not a Greek fraternity or a religious organization. I'm not going to sell you anything, don't worry. So MedChi is the Maryland State Medical Society. We've been around since 1799. We're actually the 7th oldest medical society in the United States. We're about 40 years older than the AMA. We represent physicians. It doesn't matter whether physicians are in private practice or employed or whatever. We're like the Professional Association of Maryland for Physicians, and our name is short for Medical and Chirological Faculty of Maryland. That was the name the General Assembly gave us in 1799. We're a nonprofit. We do all kinds of interesting stuff. We're the largest accreditor of CME. We actually accredited this for CME. We lobby in Annapolis. We help doctors with everything from insurance problems to salary problems to all kinds of problems. So let's talk a little bit though about what we're here to talk about, which is where we've been and where we're going. So where we're going is the waiver got extended a few months ago, and that's really good news for all of us because it means that there's going to be this continual reason for us to adapt and use CRISP in our population health, and there's all kinds of opportunities there. And that's a really big deal, not just for CRISP, it's actually a really big deal for Maryland. It's a major accomplishment for the Hogan administration that we were able to extend this thing and continue to have the extra investment in Maryland that will mean that we have the extra investment for Maryland hospitals and other healthcare and other things. And that's a really positive thing that we're going to be continuing to do this. So the future is we're going to keep working on this stuff, and that's good. But let me take a step back and talk about where we were and talk about where this kind of all began. So, and I'll do it from my perspective because that's the only one I really can do it from. Around 2008 or so, I had made a personal decision not to run for re-election. I don't think I mentioned that, but while I was working at MedChi as a young lawyer, I happened to get elected as a county commissioner. But I made this decision not to run for re-election for county commissioner for various reasons. One is I was a somewhat liberal Democrat and had been elected in a very conservative county over in Queen Anne's County, which has a whole lot of farms. For those of you who don't know what it's like, it's the first county when you cross the bridge. And I still live there today. But anyway, so I made a decision not to run again. And I also had the fortune of having the CEO of MedChi having been relieved of his responsibilities, and there was an opening. So I said, well, maybe I'll go for that job, and I'll get it. And I did get it, luckily, and I decided, okay, so I'm going to do this. I'm not going to practice law anymore. I'm not going to take a break from politics. I finished my term out. I didn't run. And I get a call from a friend of mine who says, his guy named Adam Kane, he's still on the board. He's actually on the HSCRC, and he's on the board of CRISP. And he says, you know, your predecessor had been working on this HIT stuff, and MedChi was in a kind of cabal with CareFirst and some other folks to have a collaborative that was going to do all HIE in Maryland. And it had somewhat failed and wasn't working out, and we weren't really at the table. So Adam called me up and said, you need to get involved and engaged in this. So we did, and shortly after that, the HIE was designated as CRISP, and MedChi sat down with David Horrocks and Adam and others, and we said, okay, how do we work together? And we started partnering. And the way we partnered was, we said, CRISP needs to go out and talk to the physicians and the providers and figure out how we're going to work with them and offer their services and do things. And it was focused obviously on the HIE and population health at that time. So MedChi started doing it, and eventually we started doing contracts with CRISP to go out and talk to different practitioners. So it was kind of an interesting partnership at first. I didn't quite know how it was going to work or how important it was going to be or what it was going to mean. And frankly, when I first had those initial conversations, I didn't really even understand how valuable it could be. And what we did was we partnered with CRISP, and over those handful of beginning years, we started talking on connections. We started going out and connecting doctors to the HIE and connecting doctors to begin to serve. At that time, very early on, CRISP was very focused on connecting the hospitals because of the waiver and the contract and other things, so we started doing that. But the problem we ran into, obviously, was we'd go out and we'd talk to a doctor and say, this is great, you've got to connect to this, you'll get this data, but you got to have reasons to connect the doctor. Because CRISP understands that the customer here, while they might be getting paid by the government or by some other entity, the real customer here is the practitioner that uses it at the end. And so what we started doing by working collaboratively with CRISP, and now other groups like Lifespan, who's now working with the nursing homes directly, has figured this out. You've got to figure out use cases that make sense. And some of those use cases we started working on very early were things like population health tools that could allow doctors to figure out how to make money in their practices or be more efficient or make money for their employers in their practices. So for example, we would do things like say, can we use these CRISP tools to bill an annual wellness visit or to fill out some of the information we need for that? Can we use the CRISP tools to build things like transitional care codes, chronic care management codes? And that was the thing we would really do. We would go out and do complete presentations to physicians explaining that if you signed up for CRISP and you downloaded your portal, you can then put your Medicare patients in and get alerts when they're hospitalized, and if you bring them in and bill them, you can make more money. And that was one of the keys to really getting people signed up. So when we go and talk to people and explain why we're able to get ambulatory doctors to sign up, that's the case. On the hospital side, and CRISP has teams of people who do this, obviously, we were doing things like talking about how do we hit readmission goals under the waiver? How do we meet certain responsibilities and obligations for quality reporting metrics under the waiver? Those were the types of things we did during that course of time to build things up and make it work. And that was really how we sold this to folks. And in fact, we would do presentations, and I put these slides in here because I figured you guys could get them if you were bored or interested in it. I'm sure all of you know this stuff. But again, you can really make significantly extra money in a practice, and this really doesn't matter whether you're employed in a hospital and you're making money for your employer or whether you're in private practice, if you're effectively using these tools, and that's still true today. And that was really one of our big selling points. So when other states ask, well, why are so many ambulatory doctors signed up? One is because CRISP successfully got the data into the system. And then two is we are effectively selling to people how they can use this to benefit their lives. And look, the truth is that it benefits the patients a lot too, because if the patient gets a call from the practice that they've been hospitalized and they get better care, that's good for them. But there is an economic benefit too. And honestly, a lot of practitioners are motivated by that, and a lot of hospitals are motivated by that. So those were some of the things that we did to kind of make this work. During that course of time that we've been pushing that over the last few years, as the partnership has grown and we had the outreach team and people were going out, the state around 2011, and then finally I think in 14 it started running, put forth the PDMP, and that landed with CRISP as well. And prescription drug monitoring became another program that we started working around together to help practitioners. Now that's a little bit different from the HIE tools and the population health tools, because the population health tools are really more voluntary and they're more integrated in, and we're selling them on economic reasons. The PDMP is pretty straightforward. There were lots of people dying from the opioid crisis, and the state's mandated it, and we have to do it. And CRISP has done a really good job running that, and they do really well working with the state. We have teams of people and we work together. But as time has gone on, as you can see, more and more responsibility around IT has been given to CRISP, and it's built up over time. Let me also point out, I believe there are only 2 states in the country that have both the HIE and the PDMP together. That's Nebraska and Maryland, interestingly. So that's a very unique situation and a level of trust that you don't see in other places. So that's kind of where we've been. And now we've got this incredible nonprofit that's providing these great services, and while they might not be perfect at all times, and while we might have our concerns, they're doing really good work, and they've got lots of data, and they're doing lots of stuff we need. So what's the next thing that happens? What happens as we kind of move forward into the next part of this thing? Well, it's this new model. And we've been talking a lot about it today. We've talked about the primary care program, we've talked about care redesign. This is where the real opportunity is for us going forward. And I think one of the things that we all need to think about in this room is, as we're using this, are there places where we can reach out to CRISP and say, how can we use these tools better as we try to meet these goals? And if you look at the total cost of care model, you break down what's happening, and I'm sure everybody in here is an expert in exactly in how this whole all-payer contract or Medicare waiver, which I don't think we're allowed to say anymore. I think they want us, I think the magic words they've told us we have to say are all-payer contract. But the all-payer contract or the global budgets or all this stuff, I'm sure you're all experts on it. You probably know more than I ever forgot. I know Camille from Doctors knows more than I know about it. But still, as these things happen and as these things change, it's going to create new opportunities and new use cases for CRISP. And this is where I see us really being a leader going forward, because we're going to be able to develop new technologies because of these new models and new opportunities for us to use the technology to improve healthcare and improve patient care. So let's talk a little bit about it. Well, you all know a lot about the hospital global budgets and how the hospitals have had to use CRISP to meet the quality measures and the goals around the waiver, and that's something that they have been doing for quite some time. We also now have begun doing things around care redesign, and you've heard a little bit today with some of the speakers about the Maryland Primary Care Program. Both of these are going to create new opportunities for CRISP to be helpful in trying to manage care as we move and we continue to move from volume to value-based measures in healthcare. So I guess I'm going to start with the general total cost of care model in the Maryland Primary Care Program, because that's the order I put the slides in. Maybe I should have done that, but nonetheless, it's fine. So the primary care program, and for those of you who didn't sit in Dr. Half's session earlier, essentially is this new program that was passed as a separate waiver with CMS, but is part of the whole package, of the whole waiver package. And approximately 2/3 of the primary care doctors in Maryland have signed up to agree to manage these patients, these Medicare patients, and they're going to be paid care redesign fees to do it. That's essentially how it works. They're still going to get paid their fee for service, but now they're going to be incentivized with care redesign money or care management money to manage these Medicare patients. So CRISP is going to have a really big role in this. In fact, they're going to be the principal administrator. CRISP is getting more and more responsibilities, kind of like the PDMP got added on them. Now some of these care redesign issues are beginning to be added to them. This model, for those of you who are familiar with other states, is very similar to the federal CPC Plus program in other states. So really, I think the big issue here is going to be, how do we effectively use CRISP to help these primary care doctors, some of whom have never used CRISP. I know from seeing the list that there are about 100 practices that don't even have an agreement with CRISP, so they're starting from ground zero. How are we going to get them in to use this to manage those Medicare patients and do a better job? The way this program works is the federal government is investing money in primary care in the hopes that these primary care doctors will properly manage them and save money by reducing expensive costs like unnecessary ER visits, unnecessary treatments, unnecessary utilization, and we've got to incentivize that. So CRISP becomes really important with regards to this. If we can make sure that the CRISP tools are uniform and inexpensive and useful for the primary care practice, no matter where they are, whether they're in a hospital or whether they're in private or whether it's a primary care doc affiliated with a nursing home, then it can make a big difference. And that's where there's a great opportunity. The tools we already have today, like ENS, the encounter notification, is big, because clearly if a doctor knows someone's been hospitalized or a certain thing has happened, that's helpful to them. But there's going to be more things we're going to need to develop and do, and I think there's going to be a lot of growth and opportunity around CRISP in this area moving forward. The requirements around the primary care program, and again, for those of you who didn't get to see Howard's presentation, I think they had it worked out where you're going to be able to see it at a later time or you can see it online. But the requirements are broken down into access and continuity, care management, comprehensiveness and coordination, caregiver experience, which is always a wonderful thing that you get surveyed by your patient. So if they're upset because the parking lot was full, you get knocked down. But anyway, I always find that one to be somewhat frustrating and subjective. Just make sure your staff is all nice on the intake side. Plan care for health outcomes. That's what it's going to measure and what it's going to look at. And doctors, physicians, and other practitioners who are involved in it will be eligible for bonuses for good management. So there's a real economic incentive, again, to get these tools right and to make them work and to align them with what we've got here. And I think that's a big opportunity for us in the future. The other opportunity is one that's somewhat already ongoing, and another one that CRISP is working on. And those are the care redesign programs that are part of the current waiver that we currently have and are going to be continued going forward. For those of you who aren't aware of this, there are actually two major care redesign programs. There's a hospital-based program, which is outlined on the left, and then there's the community-based program, which is on the right. The community-based one probably will fade away and become part of the primary care, so the hospital one might be the more important of the two. But essentially, these programs allow hospitals to have partnerships with non-hospital practitioners and provide gain sharing. Again, the CRISP tools are going to be key in making sure whatever measure they work on has a positive outcome. An example of a program that would fit into this would be a hospital might partner with a group of orthopedic surgeons to say, you know what, we're going to put you in the hospital care improvement program and we're going to incentivize you to do your knee surgeries in an ambulatory surgery setting to reduce costs where it's a lower cost setting, and we're going to incentivize you to have good quality measures, and if you do these things and have good quality and you reduce costs, we will economically reward you. Well, clearly, if you have a situation like that, tools where you're able to look into a portal and see what other services have been provided, or tools where you're able to get an encounter notification if they go to an urgent care center because the knee's hurting after the surgery to prevent them from ending up in the emergency room. If you hope they go to an urgent care center, don't go to the emergency room. But tools like that CRISP can use can be very powerful and very helpful. The other role CRISP is playing in this is they're the administrative staff, actually, for some of the care redesign programs and are working closely with the HSCRC. So they're going to be very interlinked in all of this. And again, I believe as we develop new programs and new opportunities for care redesign and gain sharing, it's going to be new chances for us to use these tools in more effective and other manners going forward. Currently, this is the list of the hospitals that are currently participating in one of the two gain sharing programs. So you can see there's a large amount of participation and there's going to be a large amount of opportunity. And I think the future on this is large and wide, and I think, I wouldn't bet the farm on CCIP going away altogether too. I think just because it's going to be morphing into the primary care program, I think you could see that framework being used for something else positive. I think the folks at the HSCRC are working on that today. So what are some of the tools that are going to be used and what's going to happen going forward as we work through these things? Well, clearly I've talked about practice portals and I've talked about analytics and the learning support system and the educational stuff that we're doing. And I think as we move forward and we begin to do these practice transformation issues, I think you're going to see CRISP have a more robust role in that area as well as we help physicians change their practice. It amazes me, as MedChi has been going around and helping people sign up for the Maryland Primary Care Program and working with them, how many doctors are really just beginning on a lot of this stuff. But we really see that out there. They don't really fully appreciate or understand how valuable this is. And in fact, most physicians, when you talk to them, see the EMR, see the technology as a hindrance. And the reality of it is it can be, and it can be a tool that is in between you and your patient because you're messing with your iPad instead of looking at them. But it can also be something that makes a big difference in their lives and improves their outcome. It can make a big difference if you have a tool that helps you know the other care the patient's getting, the other medicine the patient's getting, where the patient is going, or when they're going in a different direction. And I think That's what we need to do. It can also be a big benefit to physicians if you can explain to them how they use the tool to improve their economic situation. And it doesn't matter whether they're employed by a hospital or whether they're in private practice, because if the employed unit is bringing in more money, that is beneficial to them as well. And a lot of these technologies have that power if we can unlock it. So there are requirements around the Maryland Primary Care Program. They do have to have an EMR, and they do have to specifically be connected to CRISP. I don't believe there are any requirements around the care redesign programs that do that, but I think these new programs, like the Maryland Primary Care Program and like the care redesign programs, essentially mean that CRISP is here to stay, and there'll be a role for it one way or the other as far as the future of this endeavor or entity. The future with regards to PDMP, it's here. Unfortunately, we continue to have people with opioid crisis, and there continues to be pressure around that. So I don't see that changing as time goes on. And I guess the bottom line is that we're working on something that's really improving the quality of healthcare and the life of real patients in Maryland, and it's going to continue to exist and go on moving forward. So at the end of the day, I want to just think about why we're successful and give you a couple big takeaways. I think the first thing that I can't underestimate is how confident everybody is who works there, and that's a big positive, and you do not see that when you go and look in other states and compare it to that. The second thing that I think really makes them very successful is the fact they've done a very good job making partnership with key stakeholders and folks who really matter, and the users who actually use the system. CRISP has a strong relationship with Lifespan, which represents long-term care. They have a great relationship with MedChi. They have a great relationship with the hospitals. Their board is governed by people who actually understand and use the system, and I think that makes a big difference. I think the fact that they're an independent entity and not part of the state is another reason why they're successful and why they'll continue to be successful. I think by being a nonprofit that is not burdened with some of the rules and regulations around the state, it allows them to be innovative and partner in a way that's a big positive for Maryland. It makes things work in the right direction. And I think the all-payer contract and the extra funds and the investment is another reason why they're able to be successful. So if you think about the future of CRISP, it's very bright because there is a continuing source of revenue moving forward that's going to allow them to go that way. They're set up in a very positive, good way. So the last part of this being successful really is you. The key is you as the users, the people who are using it every day. You've got to figure out how to improve it and make it better. You've got to reach out and talk to the people from CRISP. Talk to your outreach team, talk to the folks there and say, you know what, if we did this a little better, it would make the patient experience better, it would make the practitioner experience better. In closing, I guess I want to say that I really appreciate the honor and the opportunity to be here to speak with you. I thank CRISP for all it's done for Maryland and for the physicians and the other practitioners and for the opportunity it's created. And for those of you who've seen me speak before, I apologize for not being as funny as I usually am. I will say I have a good excuse. I've been healthy lately and I've lost some weight. And I have a theory that when I was chunkier, I was a lot funny. And I never really understood why that was, but I do now. And the reason is when you're fatter, you eat a lot more sugar, you know, and you're in a good mood all the time. And now that I'm depriving myself of this sugar, I'm just not funny, and I'm grumpy too. So I apologize for that. But I will say this: while maybe I wasn't as humorous as I normally am when I speak, I will say that I'm very sincere in my words about what we're doing and what we're doing here. And I cannot tell you enough about it. We have an AMA meeting in 2 weeks. I'm going to sit down and talk to other CEOs from other state medical societies. They're going to tell me about money that went to an HIE that was wasted. I'm going to hear stories about HIEs that are getting large amounts of state funds and don't run a single bit of data through them. I'm going to hear stories about PDMPs that don't work or are being run on a county basis. And we don't have that here. So the next time you're annoyed because it's not working 100% right, or your portal ENS feed was a little slow, or something snafu'd a little bit, just think about it could be a lot worse. You could be in some other state where nothing works, or you don't have anything, or you're dependent on insurance companies whose interests are not the patients that you see and represent. So thank you so much for having me today, and enjoy Halloween tonight.
Thank you, Gene, very, very much. I know you're all here to hear David Horrocks' closing thoughts, so he's going to come up and just give us 5 more minutes. But first, 2 quick notes. 1, CME credit, please drop it in the bin by the registration table. And then I have Yetis to give away. So I'll read the numbers, collect them at the front. So first, orange ticket, 087002. Yellow ticket, 141054. Going fast, so also I'll stay at the front if you're close. Red, 277019. Another red, 277022. And a blue ticket, 922006. I'll stay at the front though, I went fast. So David Horrocks, CEO of Crisp, sharing some closing thoughts.
Thanks, Craig. I didn't get a ticket. I could use a Yeti. My wife took mine. She snapped it right up. And thank you, Gene. Gene has been such a great supporter of the work of interoperability and Crisp, and thank you for being our keynote. I'm just going to, as we begin again, how many of you have visited Salt Lake City? Salt Lake City, Utah. Okay, about maybe a third of us have done that. I just happened to be in Salt Lake City on Monday. I was out visiting a technology vendor, and while I was there, I explored a little bit. And I was in the Metro South part of Salt Lake City, for those of you who know the area that goes down to the cities of Sandy, Orem, and Provo. And the area is about the size, I'd say, of Baltimore and Baltimore County. It's, I think Utah has 3 million people, and that area is about half of the population. And it's very fast growing. It's, in 20 years, that area has doubled in population. And economy is very strong. They're in the very top performing quartile for unemployment and GDP growth. And they've transitioned in Salt Lake City's economy from a mining and agricultural economy to a high-tech economy, which is why I was visiting. And so as I explored, the area is built along a mountain range, the Wasatch Range. And they call it the valley. Really, everything's built in the valley. They call it the Wasatch Front. And you can climb up, and it was a clear day. I climbed up into the mountains early Monday morning, and you can see the whole thing. You can see all 50 miles from Salt Lake, and you can see Sandy and Orem, and then Provo off in the distance. And as you look at this and survey the valley, there's this ribbon you can see, a single ribbon that connects the 4 cities. It's the I-15, Interstate 15, connects this region together. And this is critical infrastructure for the Salt Lake region. It is, I was told by the business owner that I visited, it's like the lifeblood of commerce. And it was built in the 70s and expanded in the 90s. And if you count the part of the highway that runs north of Salt Lake City, 75% of the state lives within they would say, the interstate corridor, just as we live in the district, in Maryland on the I-95. Many of us are on the I-95 corridor. So the business owner was saying, well, this is so important that the Chamber of Commerce has a committee that he's on that's focused on expansion and maintenance of the I-15, and they build a light rail that runs the distance. And he said that really this infrastructure has opened up markets to him. He could never build his business in Sandy with 100,000 people or so that we're all from, but he's got a technology workforce that he's run from basically a 2 million person region. So this infrastructure has really connected a lot. It's taken time for them to build the businesses. It's taken 20 years since that expansion. They've really learned to use the highway and the light rail that runs along the I-15. They've learned to use it. They've learned to use it well. And so what's that have to do with CRISP? I think CRISP is also an infrastructure that connects things. Right? We don't connect cities per se, but we connect provider organizations. We are an infrastructure that enables a certain type of commerce, not growing GDP, but hopefully growing health and wellness. And connecting is not enough. Just as building the highway was not enough. The highway builders didn't make Salt Lake City grow. You have to learn to take advantage of that connectivity, to take advantage of the infrastructure, to learn to use it, to learn to use it well. And I think that's where we are as a region. We are learning to use the connectivity, and hopefully we are learning to use it well. So again, it's not the people who build the infrastructure, it's the entrepreneurs, the business owners, the lay leaders, all of them who will grow this thing. And so it's really all of you who will grow the activities of the health information exchange and the purposes that are enabled by interoperability. And I gotta tell you, I think you're doing great. I think you're doing really, really well. It took Salt Lake City 20 years to double. Do you know that we've doubled the amount of activity in the last year? For those of you who were in Columbia also last year at the user conference, I think we doubled the user conference in 1 year. We'll probably have to find another venue if we continue to grow like that. So thank you. Thank you for figuring out how to take advantage of interoperability and connectivity. My team and I, we're here just to listen and to support, and hopefully a lot of that occurred today. Hopefully there was a lot of listening and ideas and thoughts about how we can do even better. I'll echo Gene here. Gene said, challenged you, I think, to do more, to push, to find new ways to take advantage and to grow this. And I would say the same. Let's grow it. Let's push. Let's push ourselves. Let's accelerate. And let's see if in the next year we can double this again. So I'll close with that. And thank you for being here. Thank you for being such great partners.
Bye, everybody. Happy Halloween. Drive carefully. Thanks for coming.
That's true.